Hello, everybody, and thank you for listening to Tough to Treat with myself, Susan Clinton, and Erica Melo, my co-host. Today's episode is on red flags. Everybody has opinions about red flags. Everybody knows that we need to be able to discern if somebody belongs on our table or not. This episode kind of talks a little bit about sometimes how red flags or the need to refer can be just a little bit on the vague side, and how it becomes important to have experience as a clinician to listen to that gut feeling and really follow through if you really feel that something else needs to be attended to. Thanks for listening. We look forward to your comments. Hello, everybody. This is Susan Clinton, the co-host of Tough to Treat, along with my co-host, Erica Melo.
Hey, Susan.
Hi, Erica.
I'm good. And yourself?
I'm doing well, thank you. Erica and I have been in discussions, as you all know, with our clients and people that we see and conglomerations of types of patients that we treat together for some time. And we still even talk, off screen a lot about different things. And one of the things that we haven't really touched on a lot in the podcast, but I know that comes up in everyday clinical life, is red flags. What are some of the red flags we run into? What do we do about them? And what are more cautionary flags? So I always kind of look at people as refer and treat, or, cautionary, kind of keep an eye on something, and treat. It's kind of the way that I kind of break up the three categories for myself. And I thought it might be kind of interesting for us to just have a little bit of a dialogue about that. And there are some things that I think that are interesting that maybe people aren't thinking about, but then there are also the widely known but sometimes forgotten really, really important red flags that come up in, everyday clinical life and kind of catch us by surprise, like, oh my goodness gracious. Wow, there it is in shining lights.
I think it's funny because it's about, clinical expertise. Doing the right thing at the wrong time is not the right thing, right? I mean, you want to do the right thing at the right time, whether it's referring out or employing a certain treatment intervention. And, referring out is definitely clinical expertise. It's part of being an expert, right? So I think this is a great discussion.
All right, so one of the most interesting things that I ran into was and this is where I kind of get lulled into my comfort zone just a little bit, is when I have wonderful repeat clients. Mm-hmm. So, that's always kind of the tricky piece, is that here comes somebody that I know. I've been working with them on and off for the last few years. They just come in for, hey, I need a tune-up on this. I want to talk about my shoulder. My back has been bothering me the last few weeks. I thought I'd come in and get it checked out. Somebody that I know really well. And this is a person who probably 20 years ago had breast cancer. So this is not like a new event or a recent event or anything like that. And at that time, it was postmenopausal breast cancer. And when it's postmenopausal, it tends to be not as aggressive as prior. And so I had been treating her off and on for some shoulder stuff over the years, and great person, and she's so in tune and really knows herself well. And she just came in saying, I had this a few months ago. She kind of ended up with a sudden back issue that was giving her some radiating pain down her leg, and so she started working with a physician and went to a PT that's in her network, and just did the basic PT, and followed the extension exercises and some of the stuff. And she said, it made my shoulder worse. Okay. Right. So she said, I felt like I should just come and see you and have a once over for the whole, from the top to the feet, and kind of see what's going on. And it was interesting because I just had this little niggly thing going on in the back of my head, like, something just doesn't seem right. Yeah. And the most interesting thing was she was complaining of having the dropsies in both hands. Usually she'll say, my shoulder hurts, and then I feel like I need to drop something. I mean, that's not an uncommon complaint for her. Never really has been a big deal. But I just kind of started thinking, wow, back pain, some leg pain, the other arm is bothering her. What's going on here? She's 70, just starting to kind of put the pieces
Right.
together and ask her some questions. Any numbness or tingling? No. Any balance problems? No. Are you tripping on anything? Have you run into any, anything out of the ordinary? And she said, no. I said, we haven't done this in a while. Let's just take a real good look at everything from head to toe, because that's why she came in. She really wanted a second pair of eyes on her.
Did she have a mastectomy? With what was her after breast cancer?
She had a mastectomy, yeah.
On both sides or one side?
Just the one side.
And the side that was having the dropsies was the one of her mastectomy.
Yeah, that was like her kind of off and on neural tension arm, that kind of thing, but never really anything that made you like stand up and go,
Got it.
Anyway, for her to have all of this sudden kinds of things going on everywhere was just out of scope, out of what her normal complaints are. So when I have people that I know and all of a sudden something seems out of bounds, that's why I said the little hairs on the back of my neck were kind of starting to stand up a little bit, like wake up, Susan, pay attention to this. Let's kind of look at her with fresh eyes, and not because you know her.
Right.
Let's get out of the friendly family kind of person and into somebody who may just be walking in your door for the first time.
That's a very good point.
I had to kind of almost like snap myself out of my comfort zone with her and just go, whoops, back to, let's look at this different. So I decided to start with a neurological exam. That just felt like the thing to do. And the thing that stuck out to me was that she had her reflexes in her lower extremities were okay. She didn't have any emerging clonus or Babinski. But I'll tell you, the reflexes in her upper extremities were very, very, very brisk, and almost to the point where they seemed to be like 3+ or
like
kind
a
of
hyperreflexive.
Like really,
Wow.
No cogwheeling, no, the one where I can never remember names of tests. We talked about this the last time. But the one where you flick the third finger.
Oh yes.
Homans or Hoffmans or whatever.
Yes.
Yes. That one was okay. I really kind of expected that one to be a little bit hyperreflexive. So then I kind of like dove back into my work a while back with Earl Petman and Jim Meadows from the NIOMT world. Wow. And I remember Jim doing all kinds of crazy reflexes because he felt like that would uncover some things a little bit better. And he said that if you start getting into some other ones and they start getting brisk too, then you need to kind of start thinking, maybe something else really is going wrong. If your regular tricep, bicep reflexes are brisk, super brisk. So he had a technique where he bangs on the insertion of the levator scapula, and then he bangs on the upper trap, and then there's also the one that you bang on the jaw.
Oh, interesting.
And so going right at the masseter muscle in the jaw, going right after the levator scapula muscle, and going right after the upper trap. So I did those, and it was really interesting because her whole head moved. Oh boy. It wasn't just a like, oh yeah, popping the shoulder. I mean, there was more movement than there should have been, and it was a little bit more widespread. And her jaw really triggered off, a pretty good one too. And you could get the I
remember that.
Head coming in with that. So she had been working with a physiatrist. I know that she went to see about her back because she wanted to have an injection done for her nerve pain in her back. And when I finished with that, she said, "What did you find?" And I said, "Well, interesting, but it seems like these are really brisk, like super brisk." She goes, "You're the third person in less than 2 weeks that has told me that." And I said, "Well, when you were at your physiatrist's office, what did they say?" They said they wanted to do an MRI of my neck. And I said, "Well, what did you say?" And she said, "I was unsure. That's why I came here." And I said, "Well, what do you think is going on?" She goes, "I don't know." But she said, "I really feel like I probably should go and do that test."
Right.
I said, "Okay, yeah, I think you should." I said, "It may be completely unrevealing, but," and she goes, I think I just want to make sure everything's okay." So I asked her some other questions then as we started heading down the path. Now that I kind of found this, I'm thinking, spinal stenosis, or cervical myelopathy, a stenosis in the cervical spine. I'm still not thinking like just refer back and hands off. So I'm still kind of under that, okay, this is definitely going to be a refer and maybe a treat, but certainly not going to just be cautionary.
Right.
known her for too long that this is just kind of not something that I had seen before. And I have done reflexes on her in the past. I went back and pulled up my notes, and never anything that made me think,
Yep.
because I usually just do a quick neuro scan on people every so often.
Yeah, I think when your radar goes up as a therapist, and it comes to experience, but just you trust your gut. It really is. If you think something's not right, it's not right, and better to be safe than sorry. And and that does come with practice, but never be ashamed to refer out to somebody. And I think sometimes we think that we can figure it out, but you know what? It's not worth it.
Right.
Just not.
And especially when you see somebody who's in their 70s who's relatively healthy. I mean, she really is. She's not sedentary at all. This is a sewer and a mover and a shaker, and she's out in the community and she's doing all kinds of different things. And for her to be slowed down by something is abnormal. And she seeks help. She wants to keep moving. So it's not, like somebody, that you're just not moving at all. So I just kind of continued on with the exam. The next thing I did was I just decided, you know what, time to go to vitals. So I took her blood pressure, which was fine. Her pulse rate was okay, a little bit on the high side, running in the 70s, but nothing, for nothing really, like, she wasn't like in the 90s or anything like that, but something to keep note of. I have one of those little pulse ox things.
The oxygen saturation.
The little portable one. And that was great. So good news there. I think in somebody that age, I'm kind of thinking circulatory maybe, a little bit of something going on, particularly maybe vertebral artery kind of stuff. So we did just the basic. I don't like doing the head off the table into hyperextension and rotation. And in fact, the IFOMT has come out against that.
Yes.
And has really pretty clear guidelines on looking at it. So I can pretty much, in a normal cervical exam, take people through the motions that are going to, if they are having a vertebral artery problem, it's going to happen.
Yeah, it'll show up.
Yeah. So, I mean, we just looked at extension, we looked at side bending, we looked at rotation, in an effort to kind of see if that brought on any of those symptoms into her upper extremity she talked about, which would be just feeling different in her hands a little bit. And so none of that happened, which was really good. I was very happy about that.
Was she a smoker? No history of smoking?
No history of smoking. Yeah.
Okay. And no history of like MS or any neurological in her family at all?
Right.
Okay.
Right. Yeah. She just, like I said, is somebody that you would never, ever expect those kinds of things. I mean, she would talk about, my father always complained about something with his hand, or just general stories that people tell, because we just didn't think about things like that. And she says, I don't want to be that person. She wants to be on top of it. And I did some standing balance stuff, and none of that was really out of bounds for her age. I'm going to say that like that. So up goes another cautionary flag, because I know her and I know how busy and active she is. And she was kind of having trouble standing on one leg for longer than about 5 or 6 seconds. It wasn't terrible. She didn't like fall over or do anything like that, but I'm just looking at her going, this is an active person.
Yeah.
She should be able to do this.
Yeah.
And I know she can do it, and she was having trouble with it. And I thought, okay. So the regular, just standing still, eyes open, eyes closed, that wasn't an issue. But when I got her to do active things, then it would start to show up a little bit. She would say, I just can't figure out why I can't stand on one leg. That's kind of weird. She goes, well, maybe it's because I haven't been working out over the last 2 or 3 months. And it's like, no.
Right. Was it worse on one side, or was it equal on both?
No, it was kind of like equal on both sides.
Okay.
So starting to think a little central cordy stuff here. Yes. Whenever she did anything bilateral, like both feet on the ground, it was fine. It was when she was with one leg. But when she just walked, that was okay too. So this is real subtle. But, when you go back and you think about this stuff, sometimes when these things are emerging, That's how they start to emerge, is like
Yeah.
these little bitty sleeper things that nobody pays any attention to, and they kind of just
Mhm.
brush off as, oh, I don't know why I
Yeah.
couldn't stand like that.
And-
And they don't think about it anymore and move on with their life because it's not affecting anything
I know.
really.
I'm having like a deja vu of when I took Jim Meadows' dizziness course here in New York, and he's like, the 4Ds or something: diplopia, dizziness, dysarthria, dysphagia. And I'm
Right,
like,
dysphagia.
oh my God, right?
But she was, no drop attacks. She
Right.
was fine with her speech, talking the whole time. But you have to think about those things because it's like, what's going on here? What's happening? All of her cranial stuff was fine.
I was just going to ask that because we
Mhm.
learn the cranial nerves in school as a routine. Do we test them as orthopedic PTs? Not routinely, no. And when I took that course here, he was like very adamant about testing cranial nerves.
Yeah. Easy ones to do where you blink and hold your eyelids down. I actually kind of subtly tested her cranial nerves without her knowing. In my room, I have two windows that go to the outside world.
Mhm.
So I usually, close the shades.
Mhm.
And so the room was like darker. So I went over and I said, let's get a little sunlight in here today. It's such a beautiful day. And in Pittsburgh, that's, you grab the sun whenever you can find it.
Right.
And everybody's all in. Oh yeah, yes, have a little sunlight, So I did, but I just kind of wanted to see what would happen with her pupils. Would they start to, because it was a sudden thing of light, and that was fine. Equal. I was telling her stories. She was laughing, so I was looking for any kind of thing happening. The phase, was it?
Mhm.
Was she able to smile, frown,
Mhm.
make faces, do funny things? She was talking, so I knew her tongue was working. So there was a lot of things I could do. I had her swallow. So we did some different things, and nothing really stood out, as big. And I actually kind of had her do some talking and some stuff and make a few faces when I was doing her cervical exam, just so that when she was in, rotation and extension, to make sure that nothing was kind of going off the line that way too. And she didn't complain of any kind of other stuff. And if she had been dizzy or she was having some issues, she would have said, ooh, that makes me feel a little funny. But the only time she made notice about what we were doing was when she was standing on one leg, or when when I had her actually do something standing on one leg, such as maybe doing just a little mini squat, just to see if she could kind of pull it together. And that was when she had the most difficulty with anything motorically that we were doing.
Mm-hmm. I think that based on the history, that because she doesn't have a balance issue, that would probably be, besides the hyperreflexia and all that, definitely a red flag, or just something.
Yeah, just again, when you start pulling these things together, that's when you start getting a better picture. So the brisk reflexes on their own weren't a big deal until I started looking at the jaw reflex and banging on the levator scapula. And you pull that in, and we were seeing head movement with those, which, kind of got me. Is like, that's the head movement that, Jim Meadows always talks about. And the balance wasn't an issue, but I made her stand on one leg. And that became kind of an issue. Is that a weakness? Is that a this or that? And for, I know people out there listening going, oh, no, she's 70 years old. And it's like, this is not a person that you would expect to see a problem there.
Yeah, and I think that we throw people into boxes that way. And if you're walking into your facility for the first time, you have to look at the whole person and the picture. And if she's active and she's not having a problem walking, standing on one leg if she can't stand on for more than 3 seconds, that's really not normal. I don't care. Even if you're 70, I have patients who are in their 70s who can stand for at least 5 seconds. And I think that we tend to put them, I don't think but I think sometimes just the community in general puts these people in boxes. And I would agree, the hyperreflexia in and of itself, just okay, it's one thing. You're looking at, with this particular patient, a cluster of things.
Exactly, that's the word I was looking for, was cluster.
Yeah, and then you sort of use your clinical reasoning process to say, I know this person, I know the history, and use the clinical reasoning process to your advantage. And I think that as therapists, we do that, and we don't jump to conclusions. But when something doesn't look right, it's not right.
Yeah, exactly. So I just decided I was going to go ahead and do a couple of dural tests while I was looking at everything, since that's why she was here. And, the regular lumbar slump test was fine. The straight leg raise test gave her a little bit of radicular pain that she had been complaining of, which, by the way, that's what she saw the physiatrist for in the first place, and has been really resolving.
Mm-hmm.
So we did some neural tension tests and picked up some neural tension in the right leg that she was having problems in. So that to me, it was like, okay, this goes in this box over here.
Right.
That doesn't have anything to do with this stuff over here, because the stuff that was emerging was bilateral that I was looking for.
Any
And
upper limb?
yeah, so then upper limb tension wasn't really out of bounds at all. I mean, I knew her because, again, I've been treating her, left side and arm and chest and trunk and all of this stuff. I didn't find any real changes, in range of motion in her thoracic spine, but I did a thoracic slump, and it was interesting. So the thoracic slump, for those of you who have never used this test or don't understand it, is different from a lumbar slump in that what you're really trying to do is you're really trying to pick up some things that are coming from above the lumbar spine. So instead of, you keep the lumbar spine straight, you slump the upper trunk, and then you bring both legs up at the same time. And what you're looking for, if you're looking for radicular signs from the thorax, it'll go into the abdomen, right? Because that's where the nerves from the thorax go to, is the abdomen. Right. Or you look for any other kinds of neurological changes or things that they might complain of.
Versus a long sit slump, right?
Right.
Right.
Yeah, because we're not going after the lumbar spine. So if she had pain in her leg, I don't care. I already know what that is. I was looking for anything that might be going into the abdomen. Or any of those, just anything. And, nothing really occurred. So, and I didn't really expect it, but I thought I would look anyway, because most of her symptoms, except for standing on that one leg, were in her arms and above. So it seemed, I just wanted to make sure there, wasn't anything that was popping out in the thoracic spine. Where the cord is as well, but you never really know either until, but you have to have a reason to kind of look for something there. And she was already scheduled for the cervical MRI.
All right.
Yep. I just wanted to have a reason to call the doc and say, you should image the thoracic spine too. I just decided, okay, so that's where we were. We looked at everything else was normal, but I had these two things that just were concerning to me. So I encouraged her to go ahead and have the test done. And to make a long story short, I actually did call the physiatrist and said I'd seen her in the office, and this is what I saw. I said, I don't know how she presented with you, but let me just tell you what I found today. Besides the, very brisk reflexes, I told him about the, the standing test. And I said, and for her, this is out of bounds.
Yeah.
And he said, that's very, very, very interesting. And he loved the fact that I called him about it, because he said, I think I'm going to go ahead, before I even asked him, he said, I think I'm just going to go ahead and image her whole thorax cervical area. I just want to be sure. He goes, I just have this feeling that, I just want to know. He wanted to do the thoracic spine based on the fact that there was something kind of emerging in the lower extremity, although he said it's probably, if there's anything, it's probably cervical. But look, let's just be sure, because this is all kind of weird. And again, one of the, the interesting thing for me, the most interesting thing is, this is somebody who definitely has a history of cancer. I know that one of the things that breast cancer does do is metastasize to the bone.
Right.
I mean, that's kind of the, the course. But she's, and she did have back pain. So, but it also had a mechanical aspect to it.
Right.
That improved with the, with movement and the right things. So, but you still have to kind of pull all that together. And it's like, who's to say that there couldn't be some sort of bone neoplasm that's, I mean, it was just, so fingers crossed. She had her MRI on Friday, haven't heard anything, and won't for a little bit. So we'll just kind of see what's happening. But I just wanted to talk about that, because I think sometimes these things just pop up, and it just kind of, it's one of those moments that you have clinically where it's like, oh, it just almost like cold water on your face, pay attention.
It wakes you up.
Yeah.
Yes.
Pay attention.
No, it's true. It really wakes you up. And I had, just two quickie things. I had a patient years ago who, he came to me for a back issue. I was probably, I don't know, 3 or 4 years out at that point. And he couldn't lie on a hot pack. That's how much his back hurt. And I'm like, this is not normal. This is not normal. And he just literally couldn't take the pressure of a hot pack. And it turns out he had bone cancer.
Yeah.
And he was dead within a month, and things like that, not normal, just not normal.
Right.
And I had a patient probably some years ago as well. He came in, I had seen him on and off like you. And he came in with this swelling in his foot. And he's like, my foot's swollen. And I'm looking at the foot and I'm like, this is like right before Christmas. And I'm like, this is not swelling. I'm feeling it. You know how you feel like an edematous foot? It feels boggy. Yep. This felt wormy. Make a long story short, I sent him to actually a podiatrist he was going to at the time. I said, because this was right before Christmas, I knew he could get in quickly. Turns out they thought they needed to amputate his foot. It was like,
oh my goodness, yeah.
So to make a long story short, the guy ended up having surgery. It was a massive tumor, but they still couldn't name it. But it was a gelatinous mess is what he called it. And he's fine to this day. But it was like, this is not normal swelling and not normal lying on a hot pack. These are not normal things. And the first guy I was new to me. The second guy I had known, and he had lousy feet. His feet were always swollen. But this did not feel like normal swelling would feel, right? So I think ultimately, we just need to use our gut sometimes. Sometimes, the gut sometimes trumps reason.
Yeah, there's a reason they call it gut intuition. There's there's real neurological connections that actually give credence to that thought process. Yes. And it's one that we don't pay attention to. We're taught at a very early age to ignore it. And it's actually, whenever when they call it gut check or, those kinds of things, there's reasons for that because something isn't adding up and, it's very primal, when somebody in your tribe is not, something's going on wrong, you know it. It's like parents who know that, just know when their kid is in trouble. They just, we get some of our DNA from our children, implanted in our brains as women, with birth. There's just things that occur that are just, kind of out of the ordinary. And this was such a kind of strange type of situation that just kind of popped in. I just thought it would be interesting to talk about because if I hadn't been paying attention, I'd have just gone ahead and done my usual thing with her, and just like, okay, let's take a look at this and keep going. And I never would have gone as deep as I did. No, but just listening to her, something didn't add up when she was talking about the history that brought her back into my clinic. And so I kind of had to ask myself, and this is a great question I think for all of us to ask is, if this had not been somebody I had known, would I have gone through the trouble to do this exam? And my hope is that, yes, I would have. Yeah. Because if somebody was coming to me, I usually do a quick neurological exam on people anyway. It's just so fast, so easy. And in so many cases, it can be so revealing. And I was glad that I really actually decided to, do a deep dive.
Because her symptoms were relatively
innocuous,
fairly common, exactly. Balance 70, and you're making me want to go back to my Jim Meadows notes now and look at all those nerves and all those tests. And this was an orthopedic course I took. This was back in a while ago, but especially in direct, we have direct access here in New York. I see patients without referrals, so
me too.
So that is much more important, and it gives us credibility for the profession, right? You gained a huge amount of credibility with that physiatrist, and you represented our profession fabulously, right? And I think we need to do that still,
Yeah, I think it's important, and I think the communication was important.
Yes.
So worst case scenario, my hope is that maybe they'll find a little normal spinal stenosis, normal kinds of stuff. The worst case scenario, of course, is going to be, if they find something ugly. But my hope is that if they find anything at all, it's probably just a, mild osteophytic type of stenosis that may be going on and some emerging central cord symptoms. Yep. So it'll be something to keep an eye on. So we'll see. Kind of what happens, and I'll report back later.
You definitely have to report back. Yeah,
definitely once I know. So we talk a lot about, sometimes how what PTs think about a normal exam. One of the things I think Erica and I want to be sure that you guys understand is that we don't overlook the things that you need to examine. And I know that Erica is always looking at neurological stuff, and changes. And like you said, the feel of things, what does an edematous foot feel like? Right. What does one that's in real trouble feel like? It shouldn't be cold. It shouldn't be whatever that word was you used. I loved it, wormy. It shouldn't be,
It did feel like worms were in there.
It should, they're just things. And we have our hands on enough people to know and be able to determine. For those of you who usually ask sometimes after the podcast about different people we may bring up as people that we've taken courses from or learned some things from. Jim Meadows is in Canada and still teaches, and you can find him under his institute. It's Meadows spelled backwards, so it's called Swodeme. Swodeme, yeah. But just turn Meadows around backwards and then type that into Google and you can find him. But he is still actively teaching and treating. He's still treating patients, and I think he's great. But
he has a great book too. Out.
Yeah. Mm-hmm.
I forgot. It's a case studies in orthopedic physical therapy or something like
diagnosis.
That. Exactly. It's a great book.
Mm-hmm.
I have it on my Kindle and I have it in hardcover in soft cover. Yeah.
So always it's a good one to have and to kind of follow his clinical reasoning and things like that. He's he's the main reason that I have a fellowship in orthopedic manual therapy today. Is great. Because of him. Anyway, thank you. This was great.
This was wonderful.
I loved having the opportunity to kind of talk this through, because how it is when you find these things, you just want to somehow get it settled in your brain and make sense of it. And I use this as a real good self-reflection moment to, just remind myself that people change and things can change quickly in people. And we may be the person that actually spends the time to kind of, start pulling some of those puzzle pieces together a little bit and taking a different kind of look at the picture.
Yeah. They see us the most. So that's great. Oh, I loved it. Wonderful. Well, thank you, everybody. This was great.
Thank you.
And have a wonderful day, and look forward to seeing you guys on the next podcast.
Yes, absolutely. Thank you. Bye. Hi, everybody. I wanted to give you some good news in the update on the patient's progress and what they found on the MRI. We were very fortunate. She had a little bit of foraminal thickening at the left C5, C6 foramen. But the good news is that everything was clear inside and everything was clear in the thoracic as well. So because of her history and everything that had been going on, they wanted to be super thorough. So they did do a full MRI of the cervical and the thoracic spine. And the openings and everything looked great, no stenosis, and no creepy looking lurking tumors of any kind. So we were able to kind of stay the course and get her shoulder better, and I got her started on some balance exercises and some balance challenges so that she could continue to actually improve her balance and not let it get worse with aging. So thank you very much, and thanks for listening.